Chapter 24, Spinal Cord Injury. Before we talk about the types of spinal cord injury, let's talk about the anatomy and physiology of the spinal column first. What we want is a normal spinal cord intact, so that the spinal cord can actually do its function. There's 33 vertebrae in the vertebral column. In page 423, you can see that picture in figure 24.1. You'll see that there's a 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then 5 sacral fused into one, and then your 4 coccyx fused into one. In the bottom there, you're going to see the picture of the vertebral disc. That letter A over there, you can see that the vertebral disc is actually composed of the fibrous cartilage and pulpy tissue. And the function of your vertebral discs is a shock absorber. All right, and then spinal cord. In page 424, we will see that the spinal cord is branching from the brain stem all the way up to the L2. And then the brain and then the spinal cord is composed of those gray matter and then the white matter, where the gray matter is the one that consists those nerve cells, the bodies of nerve cells that controls the motor and sensory activities, whereas the white matter conveys information between the brain and the spinal cord. And it's in page 425. They have a cross section of the spinal cord, and you can see the gray matter and then the white matter. Okay, and then CSF, your cerebrospinal fluid, is the one that circulates through the brain and then the spinal column. And what it does is it actually bathes and protects the entire central nervous system. This is a picture of a spinal cord and the cross section of a vertebra. So right here you can see your C1 cervical vertebra, and then you have thoracic, and then you have lumbar, and then you have sacral and the coccyx. And then this is the cross section of the vertebra. We just talked about your white matter and then the gray matter, and then remember the meninges or the covering of the brain and the spinal cord. You have your dura matter, your arachnoid matter, and then your pia matter. Okay. Spinal cord injury actually depends on, it's classified by the location of the injury. Is it open or is it closed? And the extent of the damage. And these terminologies are very important for us to remember as nurses, because we use this all the time, especially if we're taking care of patients that have a neurologic problem or neurologic system disorders or injury. Quadriplegia is now known as tetraplegia. So this one is a loss of motor and sensory function in all 4 extremities. We're talking about bilateral upper and bilateral lower extremities. Okay, we call it quadriplegia, or now known as tetraplegia. Paraplegia is paralysis of the lower part of the body. The injuries at or below T2 will cause paraplegia, or the paralysis of the lower part. Okay, now let's go over page 428, table 24.3. This table talks about the degree of loss and the functional capability with injury at each level of the spinal cord. So let's go over it. So the left part is the cord level. And then it talks about the degree of loss and then the functional capability of the patient. So if you have a patient that has a C1 to C4 injury, the degree of loss will be motor and sensory function from the neck down. Obviously, the respiratory function is going to be affected, bowel and bladder control. And functional capability, we're going to need mechanical ventilation with home care. And then for C5, motor and sensory function below the shoulders, intercostal function in ventilation, and bowel and bladder control. For functional capability, has remaining head control. They can actually use the joystick for like writing and typing, and even mechanical wheelchair. Okay. For C6, motor and sensory function below shoulders, but increased degree of sensation in the arm and the thumb. Bowel and bladder control is affected, intercostal function in ventilation, functional ability or capability. They require some assistive device for the upper extremity use, but they may be able to help feed and dress themselves. Mechanical wheelchair, they might be able to use that using their joystick or the hand control. C7, motor control of portion of upper extremity sensation below the clavicle, intercostal function, and bowel and bladder control. And for functional capability, they have an increased ability to manage specially equipped wheelchair and automobile. C8, it's kind of like going down, right? The higher the degree of the damage is, of course, the more damage it is to the body. Um, so like for example, you're looking at this, you're at the C8 versus the C1 and C4, right? For the C1 and C4, up, like everything from the neck down is affected. For your C8, this one actually is, they actually might have some sensations below the chest. Motor control of portions of upper extremities is actually present. However, they might have that, still have that bowel and bladder control loss. Functional capability, they are capable of self-catheterization because they're able to move their upper extremities. T1 and T6, trunk muscles below mid-chest, they will have sensation from the mid-chest. However, the bowel and bladder control, they might have some degree of loss in there. And then functional capability is they will have complete control of upper extremities. Most of them actually have some kind of independence when it comes to their ADL. It's possible for them. And then T6 and T12, they will have sensation below the waist. There's a motor control below the waist. Okay, so for T6 and T12, your keyword is the waist. They are capable of unassisted respiratory function, and then they have good upper back and abdominal strength, making increased wheelchair activities and athletics possible. L1 and L3, this one is in the lower abdomen. They will have sensation to lower abdomen, and they will have full control of upper extremities, allows independence in wheelchair and appropriate athletic activity. L3 and L4, motor and sensory function to distal portions of lower extremities. Control of hip extensors remains, making ambulation possible with leg braces. L4 to S5. Degree of loss is variable motor and sensory function to knee, ankle, and foot. They will have sensation to the perineum, and it varies with the bowel and bladder control. Some of them might have some degree of loss. Some of them might be able to have that control. Functional capability, ambulation with braces is possible, and considerable independence in ADL can be expected. So when we talk about the location of the injuries, so for example, it happened in the cervical, vertebra, then it's going to be, cervical spinal cord injury. Or if it happens in the thoracic, obviously they're going to call it thoracic spinal cord injury. Then is it open? Is it closed? Right? They're going to call it a closed injury, open injury. And in page 426, let's take a look at this one. um, so this picture is actually showing us like what I just mentioned earlier. So for example, the injury is on the part of the vertebra, in like the cervical part of the vertebra, then you're going to have more problems because respiratory function will be affected and everything else below that. And then in that picture right there where it says compression, fracture, you see how the damage is actually like fragments of fracture, but it's close, right? It's not open injury. All right, and then we may call or may classify an injury also as complete or incomplete. It really depends on the extent to which the cord is actually cut across. So if it's just like partial cutting off the cord, then we call it incomplete. And if the spinal cord is actually severed or cut across, then we call it complete spinal cord injury. Okay, effects of spinal cord injury. So these are effects of spinal cord injury. We might have respiratory impairment, spinal shock, autonomic dysreflexia, spasticity, impaired sensory and motor function, impaired bladder function or bowel function, impaired temperature regulation, and impaired sexual function, impaired skin integrity, and disturbed body image. Okay, respiratory impairment. So what do we need to remember here is the phrenic nerve. Okay, phrenic nerve is a nerve formed by the nerve roots of C1 to C4, and this is the nerve that innervates the diaphragm. So if you recall, diaphragm is the one that's responsible for the breathing, right? Um, so if the phrenic nerve is actually damaged, then there's going to be a problem with the innervation of the diaphragm. Injuries at or above the level of C5 may result in instant death. So that is your keyword to remember, is if it's an injury that is at the level of C5 or higher, then you're gonna have an insult, may result in instant death. Okay, um, and then some patients that have this spinal cord injury, they might benefit, they will benefit from a small portable ventilator because we need them to be on the mechanical ventilator. Or some of them actually will have what we call a phrenic nerve stimulator. It's kind of like it's an implanted stimulator that actually helps with kind of like firing up that phrenic nerve. Okay, this is a picture to kind of like show us what is that phrenic nerve that I was talking about. So in here, right, it's originating from the brain and then the spinal cord, and then it's like running down here to innervate that diaphragm. And again, as I mentioned earlier, diaphragm is very important for respiration. So you can imagine how damage it will cause to a person if that phrenic nerve is actually affected. Okay, spinal shock. Spinal shock is an immediate but transient response to injury in which the reflex activity below the level of the injury will temporarily ceases. And this happens right away, as early as 30 to 60 minutes after the injury. It may persist for days, weeks, or months, and we call those areas flaccid. And then after that, when it's trying to like resolve already, then we call it the resolution phase. Autonomic dysreflexia. This is an exaggerated response to the autonomic nervous system to some stimuli, painful stimuli. This is serious and potentially dangerous, and we need to correct it right away. This occurs in patients whose injury is at or above the level of T6, okay? T6. This is one thing to remember for autonomic dysreflexia. If you have an injury that is at or above the level of the T6. What's happening is that the sympathetic is stimulated, but appropriate parasympathetic response cannot be elicited. So here's what we mean by that. This is the level of the spinal cord injury. Like I just said, autonomic dysreflexia happens when it's at or above T6. So we're gonna imagine that this is the level of spinal cord injury and that this is above your T6 or maybe at T6, okay? It's very important when we talked about the afferent and the efferent nerve signals. The brain is going to communicate to other parts of the body through those nerve signals, right? From the brain, it's going to go down using an intact spinal cord and is going to actually correct whatever needs to be corrected in the lower part of the body. Well, the problem here is there is a spinal cord injury at this level. Okay, there is a break of communication between the upper part of the spinal cord and the lower part of the spinal cord. Okay, most of the time, the reason for autonomic dysreflexia is a distended bladder, and this is what they're showing in this case as well. There's a distended bladder, there's a full bladder, and it needs to be corrected. So this is a problem that is actually occurring below the point of the spinal cord injury. And what it does is now it's going to try to send nerve signal up the spine. Okay, from the problem, it's trying to go to communicate to the brain and say, hey brain, I have a full bladder here. Okay, can you try to correct it? However, because there is a spinal cord injury, then it gets stuck here. The message gets stuck here, right? It cannot communicate properly on the upper part. So nerve signals are blocked at this spinal cord injury, causing blood vessels to tighten and raise the blood pressure. So down here, you're going to see a high blood pressure or a raised blood pressure because the blood vessels are tightened. Okay, now the brain is still trying to correct what's going on down there. Okay, it's still trying to register. I can see it, I can feel it, that there's something wrong with down here. How do I correct it? The blood pressure right here is up. How do I correct it? How about the brain is saying on this upper part of the body, how about we lower the blood pressure, right? Maybe if we lower the blood pressure, we can actually correct the situation down there. So you're gonna see that in here, in the upper part, you're gonna have some sweating, you're gonna have severe headache, you're gonna have lower blood pressure. But because of that break in communication from the upper and the lower part of the body, the brain is not going to be able to correct what is going on there. So with autonomic dysreflexia, here, let's go to the next slide. Like we said, the arterioles will constrict. There will be severe hypertension because the brain is the brain is trying to compensate from what is going on with the full bladder. causing blood vessels above the level of the injury to actually dilate, right? Because the lower part is actually constricted. So the upper part of the injury is trying to compensate, it's trying to open up, it's trying to dilate. So signs and symptoms will have, you're going to have sudden hypertension, and then the severe headache, bradycardia because the vagus nerve is actually stimulated. There's going to be some sweating, your diaphoresis, flush face, nasal congestion from the dilation, and then pounding headache because of those the problem with the blood vessels. Some of them are dilated, some of them are constricted. So your patient is going to have pounding headache, anxiety. And then again, like I said, the trigger is usually a distended bladder. So if your patient actually have a catheter, indwelling catheter, so you're gonna check, um, why is my patient having all these symptoms? Let me check if the catheter is actually kinked. So what you're gonna do is you fix it, right? Try to remove the kink in the catheter. But number one to check for your autonomic dysreflexia is a distended bladder. And then also fecal impaction could be one of them too. Again, is a blockage somewhere down there. So fecal impaction can cause it. Your stones, your urinary calculi, which is also a blockage, pressure injury, ejaculation, and uterine contractions can all trigger autonomic dysreflexia. Okay, spasticity. This is an increased muscle tone after a spinal shock. And then, of course, we're going to have an impaired sensory and motor function. If they do have this impaired sensory, your patient's not gonna know, they're not gonna feel anything below that injury. So for example, there's sitting down in a chair for a long period of time, little do they know that there's already a wound or an impaired skin integrity that is actually happening there, but they cannot feel anything, so they're not gonna know. So as nurses, we need to monitor and make sure that we're preventing this risk for skin breakdown and risk for injury. Okay, well, some patients will have impaired bladder and bowel functions. So what we do is we're gonna put them on a toileting schedule. We might need to put them on an indwelling catheter or straight catheterization. We talked about those patients in page 428 when we talked about table 24.3. Those patients that actually can do a self straight catheterization. So our goal is to just educate them and make sure that we're there for support, and we're there for education. If they need assistance, then we will give them assistance. Otherwise, we can educate them and train them on how to do a self catheterization. Then we can also do bowel and bladder retraining and give them and help them with appropriate diet. Um, Also, because of the impaired sensation, they might have a impaired skin integrity. So patients that don't feel anything, below their waist or below their shoulders, there's like bony prominences in there that we need to actually monitor for impaired skin integrity. And then they might have disturbed body image because they're going to have this, for example, indwelling catheter, right? And it actually can cause a disturbed body image because you know um, they used to be able to go to the toilet themselves, and now they're using this tube to empty their bladder. So making sure that we are still addressing the disturbed body image. Impaired sexual function too. This happens when the injury is at the spinal levels of S2, S3, and S4, because these are the ones that control sexual function. So, if they have impaired sexual function, it's still important for us to address that, making sure that we refer them or counsel them, get, some therapists involved with coping mechanisms. Medical treatment in the acute phase. So what we want to do first is to establish an airway. You always want to establish the airway first, because if the airway is not patent, there, no matter how much you do the CPR or whatever it is that you're doing, it's not going to work. You're not going to be able to save the patient's life. So establish a patent airway. I'm gonna show you guys later on the jaw thrust. Okay, and then we want to prevent further cord injury. In page 430, look at that picture in figure 24.6. This is a sample of what we call a traction. A traction helps to immobilize the spine of the patient, because you don't want them to be moving around, because if they do, they might have further cord injury. Okay, it may make it worsen. And then we can give them special beds and cushions, to prevent maybe skin breakdown, drug therapy, and then we want to preserve cord function. Maybe we may need to do some laminectomy, which is like fixing off the lamina of the vertebra, and sometimes spinal fusion. This is the picture of jaw thrust. So this is what we do to make sure that there's a patent airway for the patient. What you do is you're gonna pull or thrust the jaw up like that, and then here. This is what I'm talking about. Jaw thrust is you're gonna put your hand in this position and you kind of like going to pull it up like this, thrust it, jaw thrust, and then what you're gonna do is you're gonna open the mouth after. Okay, jaw thrust and then open the mouth after. Trivia question: one of the most serious and potentially dangerous problems for the spinal cord injured patient is? I hope you answered autonomic dysreflection, because that's the correct answer. Correct answer is C, autonomic dysreflection. Rationale: one of the most serious and potentially dangerous problems for the spinal cord injured patient is autonomic dysreflexia. This is an exaggerated response of the autonomic nervous system to some noxious stimuli. So nursing care for patients that have a spinal cord injury, we gotta make sure that we're monitoring the patient's level of consciousness, vital signs, respiratory status, motor and sensory function, and the intake and output. And these are the list of intervention that we can do to correct the situation. You want inadequate or to provide inadequate oxygenation to the patient, making sure we are preventing injury or further injury. They are at risk for injury because of the impaired sensation or even from the autonomic dysreflection that we just did talk about. Potential complications related to immobility, the pneumonia, the impaired skin breakdown, right? Loss of bowel control and difficulty voiding, potential for infection. So we make sure that we're actually monitoring them, and again educating them with hand washing, hand hygiene, infection control, prevent like things that we need to do for infection control, like if they're gonna do like a self catheterization, making sure that we're actually educating them. We don't want them to have an elevated body temperature, so we're monitoring fever, we're monitoring elevated body temperature, and giving them antipyretics if we need to. Impaired ADLs, they will have impaired ADLs, so we might need to assist them as much as we can. But again, you want them to be able to do as much as they can. However, don't force them, help them, okay? We talked about the altered sexual function and what we can do about it. Inadequate coping. So Just like the stroke, right? This is a spinal cord injury. It might come really sudden, or it will come really sudden for the patient. They're not ready for it. Just, not too long ago, I can go to the bathroom, I can walk, by myself, and now I need this wheelchair, I need this cane or whatever it is, for me to actually go to places. So they will be sad, they will be anxious. So we make sure that we address also the inadequate coping. Okay. Right then, your patient is going to for sure going into rehabilitation. These are activities that assist individual to achieve highest possible level of self-care and independence. Please highlight that part. Well-organized interdisciplinary team that can address all aspects of the function. So we're gonna have physician, nurse, PT, OT, speech therapist, dietitian, social worker, psychologist, and counselor. And then also making sure that you're taking care, not only taking care of the patient, but also the family, for emotional support and physical support for the patient, because they are going to have to do some adjustments once they are in the rehabilitation phase of after they had the spinal cord injury. Nursing care of the laminectomy patient. Laminectomy is the removal of part of the vertebra. This is usually done to relieve pressure on spinal nerves after a spinal cord injury. Okay, so what are our responsibilities? This is going to be a surgery. So pre-op, making sure that we are getting consents, or witnessing an informed consent, uh, monitoring the patient's vital signs, monitoring the baseline neurologic status of the patient, and then making sure that the education before we even do the laminectomy is actually enough and good for the patients. And then assessment, it includes the vital signs, neurologic status, breath sounds, range of motion, bladder distension, auscultating abdomen, and then the surgical dressing for bleeding, right? Because this is a surgery, and again, this is a surgery of the vertebra. So we might have some CSF drainage, and of course there will be pain. So making sure that we're addressing pain control. Interventions, same thing as what we do when we take care of patients that go into surgery, making sure that we're checking for or preventing those potential injuries, checking if they come back with, like, for example, a collar or like a brace or some or traction even, making sure that we're checking for adequate circulation, doing pain control, addressing difficulty voiding and constipation, preventing constipation, and making sure that we're educating and assisting with impaired mobility and inadequate knowledge. And that concludes chapter 24.